Recording. Right. So it's recording now.
Oh, okay.
Okay.
Right, go on, Azik. I'm going to mute myself, yeah?
Alright. So Assalamualaikum. My name is Muhammad Aziz bin Muhammad Nizruddin. I'll be presenting the intro for Jaundice. So before I start, what do you guys know about Jaundice?
It's when our blood hemolyzes and then produce yellow color, discoloration of the yellow color.
That's
Yellow
a good point.
discoloration.
Yellow discoloration. Okay, that's a good point. Okay, the actual definition of jaundice is actually the yellowing of skin, the yellow discoloration of your skin, your sclera, your mucous membrane, as a result from increased plasma bilirubin. So the takeover message from jaundice is actually you have hyperbilirubinemia. So just because you have the yellow discoloration doesn't mean that you have jaundice. Yellow discoloration of your skin can be caused by other disease also, but the takeover message is actually the hyperbilirubinemia. So the classification of jaundice, we can classify it into two types: the site and the type of the circulating bilirubin. So there are three actually side of the problem. We have prehepatic jaundice, and post-hepatic jaundice. I'll explain later. And for the type of circulating bilirubin, we have two types of circulating bilirubin, which are conjugated and unconjugated. So unconjugated bilirubin is seen in prehepatic jaundice, while conjugated bilirubin is seen in hepatic and post-hepatic jaundice problems, as you can see here. Jaundice is also known as icterus. We'll use this term a lot in our later presentation. So this is important formula to take note. Just know this lah, the reference range, total, direct, and indirect. So basically, we have total bilirubin is equals to direct bilirubin plus indirect bilirubin. So the TLDR, direct bilirubin, direct, conjugated, indirect, unconjugated. Total, direct plus indirect. That's all. The reference range is just there. So before we move on to the pathology, we must know the physiology first. So we must know the bilirubin metabolism. I take this from lecture note.
Just a minute there, guys. I believe we have a bit of a technical issue.
Okay.
Azik, what does it mean by conjugated? Why is it named as such?
Doctor, just a minute. I think.
Doctor, you're lagging a bit, Doctor. Hello?
Okay, you're back.
Okay. Where was I?
Doctor had a question.
Did I present the physiology?
No, you haven't this slide.
Did I present this already? The total. What's your question, Doctor? Sorry, I turned DC.
Okay, so this one. My question is this one. Okay, so you're going to explain later regarding direct and indirect bilirubin, right?
Yes. What's your question, Doctor? Sorry, I turned DC. I didn't get your question.
So my question is, why does it term conjugated? What does it mean conjugated?
So for bilirubin, so I'll explain in this slide, but actually, as you can see here, during the third or fourth point, bilirubin, unconjugated bilirubin is actually the direct result from the hemolysis, from the breakdown of red blood cell. So you have heme and globin. Globin is actually amino so it will be taken, and heme will be iron or unconjugated bilirubin. So in order for this bilirubin to be conjugated, it will be needed to be taken up by the liver, and the liver will have this enzyme to conjugate the bilirubin and the bilirubin will be known as conjugated bilirubin. It will be conjugated by the glucuronic acid. Yeah, glucuronic acid. So, in order to understand, I'll start first from the first point. So, from hematopoiesis, either medullary or extremity doesn't matter. We have this red blood cell. Red blood cell have around 120 days of lifespan. So, after 120 days, or if there's actually some pathology, the red blood cell will undergo this process known as hemolysis, and it will break down into two products, heme and globin. Globin is amino acid, and amino acid will circulate. That's not important now. What's important is actually heme. Heme will be further break down into iron. Iron will be circulating in our body, and bilirubin, which are unconjugated. This unconjugated bilirubin is actually non-water soluble. It's actually lipid soluble. So because this molecule is not water soluble, you need to have this transporter or protein. So this unconjugated bilirubin will be taken into the liver via albumin. So breakdown, yeah, will be taken into the liver by albumin. So once bilirubin is there in the liver, it will be conjugated by glucuronic acid into conjugated bilirubin. So this conjugated bilirubin, as well as bile, will be drained down through the common hepatic duct, common bile duct, into the small intestine. And around this terminal ileum to colon area, the glucuronic acid will be removed by the bacteria in the colon. So this conjugated bilirubin will be converted into urobilinogen. So around here, most of the urobilinogen will be oxidized into stercobilin and will give the feces the brown color. Some of the urobilinogen, however, will be absorbed through the enterohepatic circulation and then enter via the portal vein and recirculate into the liver. Some of the urobilinogen, however, will be transported by the blood into the kidney and give the urine its and give the give the give the urine its yellow color. That's okay. So this is the TLDR, the three types of jaundice. I'll try to make this simple. We can further differentiate it into three types: prehepatic, hepatic, and posthepatic. So for prehepatic jaundice, we have all these blood related before the liver. Hepatic jaundice is related with the liver up to the common bile duct, and post-hepatic is um, after the common bile duct, whether there's obstruction here or something related with the drainage of the urobilinogen or no, conjugated bilirubin. So the apa the examples for the types of jaundice for prehepatic, there are transfusion reaction, which is now not that common, sickle cell anemia, G6PD, thalassemia, IHA, autoimmune hemolytic reaction. For hepatic, we have hepatitis, Hep A, Hep B, Hep C, Hep D, Hep E, cancers, cirrhosis, congenital disorders such as Crigler-Najjar, and drugs such as PCM overdose. For post-hepatic, we have gallstones, cholelithiasis, inflammation, scar tissues or tumors that blocking the flow of bile into the intestines. So about this tumor, there's this law known as Converse's law that states in the setting of palpable gallbladder and the patient have jaundice, it's unlikely to have some obstruction. It's likely to be malignancy. So take this in mind lah. Palpable gallbladder, jaundice, cancers, Corvus's law, cancers. So about prehepatic jaundice, I'll be touch this a bit, and then Tanyan will take over. So this is our case, prehepatic jaundice. So I'll give you 1 minute to read this lah. Okay, so about this case is about Miss Hodder, a 26-year-old journalist that presents to the GP complaining of increasing fatigue. She claims that she is usually a highly active individual who runs a lot twice a week and is always up for a party. This implies that she's very active lah. Over the past month, she has become unusually tired. At first, she put this down to a flu or something, but her fatigue and lethargy have remained, and she is worried about getting shortness of breath, because she gets shortness of breath when she goes for even a gentle run. So it gradually becomes worsen. Her periods is normal. Her periods have not been unusual in any way, but she has noticed that her eyes are yellowish, and she thinks that her skin might be slightly yellow. Her family history, however, is unremarkable. On examination, we can see that Miss Hodder is indeed ictery and jaundice. Her spleen is palpable just below her left costal margin. The rest of the examination is unremarkable. A question to the audience: is our spleen normally palpable?
No.
No.
So, what do you guys think if the spleen is palpable?
Splenomegaly.
Alright, thank you, whoever that answered this question. I cannot see.
What
So,
Sorry, Haziq tanya, what does it mean if there is palpable spleen? There is splenomegaly, correct? But what does it mean? What does it imply?
Extra hepatic.
Extra hemophoresis.
Yes, that is.
and okay, let's finish the investigation first, and then we move on to the spleen because it's related also. So, we can see the investigations. Touch up a bit. Tanyan will touch up more about this and the PE. We can see the hemoglobin is 9.2, RBC is 3.6, MCV is 95, white blood cell is 4, platelets is 210, retic count is 6%, INR is 1.05, total bilirubin is 72 microam, conjugated is 7 microam, and blood film, there are evidence of spirocytes and reticulocytes. So in these investigations for FVCs and blood films, we can see that the normal part are hemoglobin, retic count, total and conjugated bilirubin, and blood film. Who knows the normal number for retic count? Is this high or is this normal? Okay, actually retic count. For retic count, the normal reference range is actually 0.5 to 1.5.
5.
So, because the retic count is 6%, it is abnormally high. And for hemoglobin, it is 9.2 gram per deciliter. Is this, we know for sure the patient is anemic lah, but what type of anemia is this? Mild, severe or moderate? Mild, moderate or severe?
Severe.
Moderate.
Moderate.
Okay, it's actually mild anemia. I'll explain later. There's a reference range later. For total bilirubin and conjugated bilirubin, what can you deduce from this? The total bilirubin seems
Unconjugated.
normally high.
Unconjugated.
Why is it unconjugated?
Hemolysis.
Pre-hepatic obstruction.
No, there's no prehepatic obstruction. That's right. It might it might be happening because of hemolysis or something or anything congenital, mostly hemolysis. But actually, what I'm trying to say is the total bilirubin is 72. So 72 minus 7 is 60 something. That's a lot for unconjugated. So we can know for sure that's unconjugated hyperbilirubinemia. So for blood film, there's evidence of spherocytes and reticulocytes. Tannen will explain about this later. So this is the takeover message from the case. Patient is icteric, yellowish eyes, and jaundice, yellowish skin. The hemoglobin is low. This is the reference range, and it indicates the patient have mild anemia. The RBC count is normal. Normal MCV levels indicate normal cytic anemia. High retic count, as I mentioned before, retic count is 0.5 to 1.5. And there's presence of reticulocyte and spherocytes in blood film. Okay, so this history is we actually took this from Oxford Case in Medicine and Surgery, and it's not complete. What do you guys want to ask further for this misorder? If let's say the investigation is not there and the PE is not there, we know the shift complaint, we know the onset is for the past month, it gradually become worsen. What else do we want to ask the patient, the misorder?
Past medical history.
Past medical history, yes. What do we want to ask about misorder, the past medical history?
Any medical problem. Anemia.
Any anemia before, any hepatitis. So if let's say I say that if let's say the patient, we know for sure that the patient family history is unremarkable, so we can rule out any inherited disease such as G6PD, but the patient is woman, so it's unlikely. For drug history, is it important for this?
Important.
Yeah, drug history is important also because we know if the we want to know what type of medication that patient took. So let's say the patient took sulfonamide, it might aggravate the hemolysis, PCM overdose for hepatic jaundice, etc. etc.
Haziq is lagging again.
Yeah, Tanin Arsa has it lagging.
Hmm?
Just a minute.
Pardon? I'm lagging. Hello?
Other symptoms.
Like?
Eh, am I in?
Yes,
Yes.
you're in, but we lost your slides.
Where was I?
Slide.
Present back
Slide.
the slide.
Yeah. Sorry, doctor.
We
Do
should,
it.
like what Amiro said, we should ask other symptoms such as, is the patient having any nausea or headache, loss of weight, loss of appetite?
Right. Okay, what else? Regarding the jaundice itself, you haven't finished the jaundice itself, it's representing illness, right? So don't you want to ask about urine color, stool color, things like that?
Yes, we should.
Yeah, and then what else you want to ask? How about others? We got 60 participants.
Doctor, since my internet is not stable, can I let my group mates present for me because I'm afraid that I will disconnect it.
10 should be okay. Okay. So I think the most important thing to ask here, because this is clearly hemolytic jaundice, right? And you know the official diagnosis would be hemolytic anemia of any causes. One of it was autoimmune diseases, autoimmune hemolytic anemia. So you have to ask about autoimmune symptoms, connective tissue diseases, such as
SLE.
SLE. So you should ask about rash. This is a young lady, in which the prevalence of SLE has the preponderance on it, isn't it? Young women. Okay, so SLE likes this type of demography. What else? Joint pains. Isn't it? You have to ask this. Okay, so these are the important things in pre-hepatic jaundice. Okay, what else? Tanan, do you want to continue?
Yeah, I'll take over from here.
Yeah.
Haziq, do you have anything to add on before I continue?
I didn't know IDC time bila, so I don't know. My point dah habis actually, tapi IDC time bila ni? What's my last point
Yeah, we're just talking about your history of presenting illness. You ask about what else to ask, right, in the history?
Oh yeah, I think I'm done for my part.
All right, thank you, Haziq.
Okay, just a minute.
Alright.
Yeah. So yeah, I'll continue. Can everyone see the slides?
Yes, Tanan.
Alright, so hold on. So yeah, what do we know from this case is the patient is icteric. Icteric is how we describe a patient is jaundice appearance, where the patient has yellow eyes, and the patient is jaundice with yellow skin. The patient is a low hemoglobin count, where the normal hemoglobin count is between 12.0 to 15.5 grams per deciliter, and red blood cell is between 4.2 to 5.4 million cells per MCR, which and the patient also has low RBC count levels, which indicate anemia, a mild anemia. The patient has normal MCV levels, which is seen over here, and the normal levels are between 80 to 96 FL, which indicate the patient has normocytic anemia. However, the patient has a high reticulocyte count, and there is a presence of reticulocyte and spherocyte in blood film. Both of these will be explained later on about why there is a reticulocyte and spherocyte seen in the blood film. Okay, so this is an anemia reference range, where a mild anemia is between 9.0 to 10.9 grams per deciliter. A moderate anemia is between 7.0 to 8.9 grams per deciliter, while a severe anemia is anything below 7.0 grams per deciliter. Now here's the pathophysiology of prehepatic jaundice. Previously, Haziq explained on how the total pathway of this jaundice occurs. So in extravascular, there is two types of hemolysis seen in prehepatic jaundice. So there is extravascular hemolysis and intravascular hemolysis. So extravascular hemolysis is when there is an increased breakdown of red blood cells within the spleen. So extravascular, out of the vascular system, in the spleen. So when there is extra work being done by the spleen to break up the red blood cells, this leads to splenomegaly, which is seen in our patient. Intravascular hemolysis, however, is hemolysis that occurs in the circulation. In both type of hemolysis, unconjugated bilirubin will be the dominant type of bilirubin seen. Now, there are several causes of intravascular and extravascular hemolysis. Causes of intravascular hemolysis consist of congenital and acquired. Congenital being G6PD-H, pyruvate kinase deficiency, sickle cell, thalassemia. Acquired could be artificial heart valves, blood group mismatch, DIC, or even malaria. Now, extravascular hemolysis also consists of congenital and acquired. Congenital being hereditary spherocytosis and acquired being autoimmune hemolysis. Now, this will be important in our case, okay? For extravascular hemolysis, congenital and acquired. Now, back to our case. So previously, I said in our case, we saw reticulocytes and spherocytosis in the blood film, right? So reticulocytes seen in the blood film indicate that there is a compensatory mechanism going on, whereby when there is an increased breakdown of red blood cells, the bone marrow compensates that by increasing the reticulocyte to compensate for the loss of red blood cells. Um, when there is an increased turnover of red blood cells, the bone marrow can't keep up to that increased breakdown, so it starts sort of spitting out halfway produced red blood cells. So when it's in the reticulocyte stage, even before it becomes a mature red blood cell, the bone marrow is already starting to throw that out into the circulation to compensate for the increased loss. Spherocytosis is when worn out macrophages, when they go to the spleen, worn out red blood cells, when they go to the spleen to be broken down, there are macrophages within the spleen called splenic macrophages. Now, these splenic macrophages sort of nibble on these red blood cells, causing the red blood cells to turn into spherocytosis. And when there is an
Spherocytes.
increased number of, when there is an increased breakdown of red blood cells, a lot of red blood cells are present within the spleen, and the spleen isn't able to cope with the increased number of red blood cells. So some red blood cells are only halfway being sort of broken down. So when they re-enter the circulation, they appear as spherocytes. They are normal red blood cells, but sort of nibbled down by macrophages. Going on. Extravascular hemolysis, the two causes were hereditary spherocytosis or autoimmune hemolytic anemia. So now, like I said previously, the patient has no family history of anemia, which allows the exclusion of hereditary spherocytosis, because hereditary, as we know, is a hereditary condition. So this allows our patient to be listed as one final cause, which is autoimmune hemolytic anemia. This patient will also have normal levels of ALP and ALT if we do a liver function test, since it is a pre-hepatic cause of jaundice. Now, speaking of ALP and ALT, I will do a short explanation on what ALP and ALT is. So when we perform a liver function test, we are looking for all of these parameters. There are about 7 parameters here. So these are the reference ranges for liver function tests. However, these reference ranges are different according to your local laboratory results. Okay, but these are sort of the average results that you'll be looking for. I don't think it's required to remember these values. So this is important. ALT is concentrated within hepatocytes. So increase in ALT, hepatocellular injury. ALP, however, is concentrated within the liver, bile duct, and bone tissues. So ALP is slightly less specific to its counterpart of ALT. Now, ALP, a rise in ALP would be seen in cholestasis. Okay, GGT, however, is found within the biliary epithelium. It is specifically found within the biliary epithelium. So, marked ALP rise together with GGT would be cholestasis, because it is found in the biliary epithelium. Cholestasis, so stasis, we know there is a obstruction to bile flow. Stasis is an obstruction to flow. So cholestasis is an obstruction to bile flow. So since GGT is found within biliary epithelium, a rise in GGT would suggest cholestasis. A rise in AST levels indicate liver damage similar to the precursor of ALT. And however, AST is also less specific compared to ALT, where AST is also found in the heart and in the kidneys. Now, similar to how I said previously, ALP is also found in the bone tissues. Isolated rise in ALP where only ALP is risen would not suggest of liver damage, but it will be suggestive of any bone pathology, because ALP is also found within the bone tissues. So it could be due to bony metastases or primary bone tumors or recent bone fractures. If the patient, now this is important, if the patient is jaundiced but has no rise in ALP or ALT, it is suggestive of a prehepatic cause of jaundice, such as Gilbert syndrome or hemolysis. So in our patient, like I stated previously, there will be no rise in ALP or ALT, since it is a prehepatic cause of jaundice being autoimmune hemolysis. These are the other factors not related to our case but also found in liver function tests. Decreased albumin levels would indicate inflammation of the liver or nephrotic syndrome, since albumin levels indicate the functional level of the liver. Prothrombin time, however, is the measure of the blood's coagulation tendency and how well the liver can help coagulate the blood. In the absence of secondary causes such as anticoagulant drugs and vitamin K deficiency, an increase in prothrombin time can indicate liver disease and liver dysfunction. Moving on to physical examination, in our patient we would see splenomegaly. Now, the most common complaint in patients with splenomegaly is mild, vague abdominal discomfort. The patients may also experience pain, which may be referred to the left shoulder. Increased abdominal girth, however, is less common. So you see pallor, fatigue, and jaundice. These are three common signs seen in patients with hemolysis. The presence of splenomegaly over here due to hyperfunction of spleen seen in extravascular hemolytic anemia. So in grade 0, there is normal impalpable spleen. 1 spleen palpable, 2 is palpable the mid-clavicular line, 3 is spleen expand towards the umbilicus, over here you can see. 4 is goes past the umbilicus, this is the umbilicus, 4 goes past. And 5, the spleen expands towards the symphysis pubis. So in grade 5, the spleen is already huge, massive splenomegaly. Now this is a test to detect anti-erythrocyte antibody. So this is a lab test that will be done in the case where we have autoimmune hemolytic anemia. So if you suggest and your diagnosis is autoimmune hemolytic anemia, you need to perform a labs test, a laboratory investigation called Coombs test to confirm your diagnosis. So there's a short video over here I think you can all watch to understand how Coombs test, because I believe this video explains it very simply. Can everyone hear?
Yeah.
Everyone hear?
Yes.
In this
Yes.
video, we will discuss the Coombs test. And before discussing the Coombs test, it is very important to understand the concept of the autoantibody. So this is an RBC, and on the surface of the RBC, there are lots of antigens. For example, the ABO blood grouping antigens, the RH antigens, and many others. And in some conditions of the body,
Yeah.
for example, the immunohemolytic anemias, the body produces certain types of antibodies which are directed against these antigens. And these antibodies attach to these antigens and cause immune mediated destruction of the RBCs and lead to anemias. And this antibody is known as the autoantibody. And the Coombs test is a test which is done to detect these types of antibodies. So there are two types of Coombs test, the direct type and the indirect type. And the common thing in both of them is the Coombs reagent. And it's very important to understand the Coombs reagent, how it is made, what is it, to understand the basics of the Coombs test. So let's first understand how is the Coombs reagent made. Please excuse me for my drawings, but let's suppose this is a human, and the body of this human contains lots of these autoantibodies. So what we do is we take the blood from this human and we separate the serum from this blood which contains all of these autoantibodies. And what we do next is that we inject this serum into an animal. Please don't ask me what type of animal is this, it just is. Now the immune system of this animal recognizes these antibodies as foreign and produces its own antibodies against these. And what we do next is we take the blood of that animal and separate those antibodies which the animal has just produced against these autoantibodies. And we harvest those antibodies, and this is the Coombs reagent. So the Coombs reagent is nothing but the antibodies which the body of the animal has produced against these autoantibodies. Let's first talk about the direct Coombs test. And out of the two types of the Coombs test, this is the one which is used to detect the immunohemolytic anemias. So let's suppose this is a human which has immunohemolytic anemia, and his blood contains autoantibodies which are directed against his RBCs. So what we do is we take the blood sample from this patient and we put that blood into a test tube or a beaker. So here are the RBCs which are present in the blood of this patient, and here are those antibodies which are attached to the RBC surface. And to keep things simple, for the rest of the video I will refer to these autoantibodies as blue antibodies and the antibodies which are present in the Coombs reagent as green antibodies. So what we do next is we add the Coombs reagent which has these anti-autoantibodies or the green antibodies into this blood sample. Now since these green antibodies are directed against these blue antibodies, when they react, they cause the attachment of these blue antibodies. And since in turn these blue antibodies are bound to the RBCs, it forms a agglutinated mass of the RBCs at the bottom of the test tube or the beaker. So here is the agglutinated mass of the RBCs, and this is a visible reaction which confirms the presence of autoantibodies in the blood sample. And one of the very important conditions in which the direct Coombs test is done is the hemolytic disease of the newborn, which is also a type of immunohemolytic anemia. Now let's talk about the indirect type of the Coombs test. And this test is mainly done for the prenatal screening of females for detection of Rh antibodies. Sorry, this is a writing mistake. This is antibody, not antigen. Now let's suppose this is a pregnant female, and again, excuse me for my fantastic drawings. And let's suppose this is a fetus inside her womb. The female is Rh negative and the fetus is Rh positive. So what happens is sometimes at the time of the parturition, the fetal blood comes in contact with the maternal blood, and the maternal blood develops anti-Rh antibodies against those RBCs. And during the second pregnancy, if the fetus is again an Rh positive human, the antibodies these cross the placenta and destroy those fetal RBCs. So it is very important to detect those antibodies. So what we do is we take the blood from the female, and after some procedures like washing and centrifugation, we separate the serum from the blood and we add the serum into a test tube, same as that of before. And here lies those antibodies, the anti-Rh antibodies. Now, here is the essential step which is different from that of the direct type of the Coombs test. Now, since the maternal blood does not contain those RBCs to which these anti-Rh antibodies will bind, so we will have to introduce externally the Rh positive blood. So the next step will be addition of Rh positive RBCs either of the animal type or the human type into this sample. So again, these antibodies will bind to these Rh positive RBCs. And the next step in this are the same as that of the direct type of the Coombs test. So when we add the Coombs reagent into this sample, these antibodies again bind to these anti-Rh antibodies and cause the agglutination. So agglutinated mass of RBCs is formed at the bottom of the test tube. So this was all about the Coombs test. I hope you find this video informative. Make sure to hit the like button below, and also if you want more videos, don't forget to subscribe. Thank you so much for watching this video.
Alright, so that was a very good explanation on the Coombs test. Just a minute. You all can hear me right?
Yeah.
Yes, can.
So yeah, when we suspect a case of autoimmune hemolytic anemia, to confirm your diagnosis, we need to perform this test called the Coombs test. I believe we did this in our pre-clinicals during lab. I can't remember which year. Okay. They're playing the video again. Yeah. Okay. So there are two types of autoimmune hemolytic anemia, being warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. Only several small differences here. First, the immunoglobulin present in warm is mainly IgG, while in cold it's IgM. To remember it easily, typical pattern on Coombs, you can see since warm is IgG, you'll see IgG positive. Cold is IgM, so you'll see IgG negative. In peripheral smear, you'll see spherocytes, and meanwhile in cold, you'll see erythrocyte agglutination. Clinical manifestation, both are almost the same. And in associated condition, for warm, you'll see autoimmune conditions, CLL, NHL drugs, and in infections, in cold autoimmune hemolytic anemia, you'll see mycoplasma infections and B-cell lymphomas. So the two main things you'll see is that for warm autoimmune hemolytic anemias, the anemia occurs in a warm environment, being 37 degrees Celsius. Meanwhile, for cold autoimmune hemolytic anemia, the anemia occurs at a lower temperature, somewhat from 4 degrees Celsius upwards to below 37 degrees Celsius. And that will be all for pre-hepatic jaundice. These are my references. Thank you. Moving on to hepatic jaundice.
Okay, thank you, Tamin and Haziq. Any question from you guys? No? Okay. Any question you can just put in the chat forum as well. So you can continue.
Okay, good afternoon to doctor and all my friends. So I will continue to explain on hepatic jaundice. Next slide, please. Okay, since there's a explanation on the pathophysiology of jaundice before this, so in this diagram, please focus on the dot column with the dotted line, where this is the main causes of hepatic jaundice. When there's any problem that happens, that cause there's problem in the uptake, the conjugation, and also excretion of bilirubin in the liver. Next. So the causes are due to pathology in the liver, includes problems of the hepatocyte and also intrahepatic bowel canaliculi, for example, viral hepatitis, Hep A, B, C, and so on. And then most common one will be alcoholic hepatitis, hepatotoxicity caused by drugs or any hepatotoxin, cirrhosis, carcinoma of the liver, and some congenital syndromes such as Gilbert syndrome, which is more common, and Krieger-Najjar syndrome, and also intrahepatic cholestasis such as autoimmune cholangitis, recurrent idiopathic cholestasis, and for infectious disease such as leptospirosis and severe malaria. But I think infectious disease are more to pre-hepatic causes because both leptospirosis and severe malaria will cause hemolysis. Next. So here's an example of hepatic jaundice. So Mrs. Salko, female, 36 years old, and unemployed attorney, and her chief complaint is her eyes are yellow for 2 days. So for the history of presenting illness, she found yellow discoloration of her eyes, noticed 2 days ago while she was washing her face, and she thought the colors were due to lightning in her bathroom. And she only confirmed that her eyes and her skin look yellow this morning when she go outside of her house. She also feels sick and tired for the past 2 to 3 weeks and also feel frequent nausea. And last night she got a fever and she described as shock all over with a chill. And she has a restless night with pain all over her body. And this morning she felt a fullness in the right upper abdomen. And in between these few days, she has non-bloody vomit twice and no diarrhea. She also has loss of appetite, which caused her to eat a little, and loss of weight around 20 pounds during the last 3 months. She has no back or shoulder pain and no joint pain or skin rashes. Next. So for her past medical history, she is a chronic alcoholic and has been hospitalized on several occasions for alcohol-related problems, including a psychiatric admission. And at her age of 28 years old, she has a spontaneous abortion, which requires hospitalization, but she's unsure about blood transfusion. For drug history, she takes Tylenol, which is one kind of paracetamol for frequent headaches. And social history, she's estranged from her husband and having an affair with a man who used intravenous drug and has a history of hepatitis. She does not use any intravenous drug, and she had many alcohol-related work problems and lost her position at a prestigious firm 3 weeks ago and started to consume approximately 1/5 of vodka every day. She smokes 1 pack of cigarettes per day, and last year she went to Mexico with her boyfriend. So this is a case we found online from a website of medical school. Next. So after reviewing the history part of the patient, so there are some points we need to elicit during the history taking. First of all, for history of presenting illness, we need to ask for the onset and duration for the jaundice and the associated symptoms such as fever, loss of weight, loss of appetite, any abdominal pain, any vomiting, any pruritus, and any back, shoulder, joint pain, and rashes. We also need to ask for the color of urine and stool. And then we can further ask on her immunization history, whether did she receive any Hep B vaccination. About her past medical history, we can ask if she had any hepatic disease before, and also inflammatory bowel disease, which may contribute to primary sclerosing cholangitis. And for past surgical history, did she receive any recent surgery procedure that may related to her pancreas or biliary ducts? And her drug history, like just now, Kanin or Haziq mentioned that paracetamol, it may cause overdose and lead to damage to the liver. And did she take any intravenous drugs, which may contribute to viral hepatitis? For family history, can ask about jaundice, such as which leads to the familial syndrome like Gilbert syndromes and also Crigler-Najjar, and any liver diseases in his family members. And social history will be important for the case of jaundice. First of all, we can ask about the occupation, whether is he or she a sex worker, healthcare worker, which they may have a possibility of needle injury, and then any exposure to hepatotoxin, and then did she or he consume alcohol, which may lead to alcoholic hepatitis. Is he or she a smoker? Any recent blood transfusion, injection, or tattoo? Any recent high-risk sexual behavior? And ask about the travel history. Maybe he or she will travel to hepatitis A endemic area, so there will be higher possibility for her to get infected. Next.
Sorry, Chang.
Yes,
Keep
doctor.
that. Keep end that slide. Okay, so apart from those two drugs, what other drugs should you ask?
Apart from paracetamol and intravenous drugs, any drugs that may lead to liver injury?
Such as?
I don't know.
We can ask for
I know
anti-malarials,
you know. Ravina.
anti-malarials to see if got any hemolysis or not.
No, drug history means before he got this illness, he took this drug. Antimalarial is the thing that you give, right?
Yes.
One only can cause jaundice. So before he got this jaundice, she took this drug. What are the most common? I mean, quite common lah nowadays.
Contraceptives,
Statins.
statins,
And don't forget about traditional medicine, complementary medicine. You know, ubat kurus, ubat putih. You know, all these things have some hepatotoxic drugs. Okay? Yeah, so complementary and traditional medicine important cause for hepatitis.
Liver injury.
Yeah, drug-induced hepatitis. Okay, and then your travel history, apart from hepatitis A, so I agree with Ravina, you should ask about travel to malarial endemic area as well. Yeah, so yeah, these are the two things. Otherwise, very good.
Next slide. Okay, so this is the physical examination of the case. So she is alert but haggard looking, skinny and shows prominent cheekbones. Her clothing is disheveled and her hair is uncombed. She appears much older than her stated age. So her vital signs is blood pressure 104/60, heart rate 110 per minute, which is regular, respiratory rate 18 per minute, and temperature is 38.9 degrees Celsius. So on the systemic examination, she has a bilateral deep conjunctival icterus, And on examination on the chest, she has prominent ribs, lungs are clear to percussion and auscultation, cardiovascular, soft S1 and S2, no murmur or extra cardiac sounds. On the abdomen is round and slightly tympanitic. The liver is palpable beneath the costal margin and tender. The liver span is 20 centimeter, which is larger than normal. Normal will be less than 30 centimeter. There's no rebound tenderness, shifting downers or splenomegaly, and she has normal bowel sounds. And upon the examination on skin, she is icteric, and there's spider nevi noted on her shoulders. And on extremities, she has bilateral tremors of hands and bilateral palmar erythema. Next. So during physical examination, this inspection palpation, percussion, and auscultation, I'll just focus on abdomen. So for inspection, we look for the general body habitus, any jaundice on the skin, and any scratch marks and bruises over her skin. And then face and neck, jaundice on sclera, parotid enlargement, xanthelasma, and the smell, any alcohol smell or fetal hepaticus, on and inspection on the hands, any palmar erythema, clubbing, leukonychia, Dupuytren's contracture, and flapping tremors. On the chest, we can look for spider nevi. If male, we can look for gynecomastia and look for the condition of her or his body hair. And abdomen, we look for any scars, distensions, and the appearance of the umbilicus. And on palpation, we can palpate is there any hepatomegaly, any splenomegaly, or any enlarged gallbladder. On percussion, we also can percuss for any splenomegaly and hepatomegaly, and also fluid trills and shifting downers for ascites. And on auscultation, we can auscultate for the bowel sounds and also breaths. Next. And next, I will pass to Ravina for investigation and management.
Chang, why
Yes,
do these patients, sorry Chang, why do this patient has gynecomastia and sparse body hair?
Gynecomastia and sparse body hair may be due to high estrogen because the liver are unable to excrete out.
Yeah, okay.
Thank you.
Okay, so I'll be continuing for the investigations for hepatic jaundice. So generally, there are four main types of investigations that you could do for any type of jaundice. So the first test that you should do is blood test. So in blood test, look for LFT liver function test. You can look for serum albumin and serum bilirubin as well as prothrombin time. Other than that, as for liver biochemistry, you can see for serum aspartate level and alanine aminotransferase ALT levels. So an increase in these two, AST and ALT, reflects hepatocellular damage. And for serum alkaline phosphatase ALP and GGT, an increase in ALP and GGT reflects cholestasis. So other than that, in the blood test, you could also see for any viral markers if the patient is affected by any hepatitis A, B, C, or D. And then for additional blood investigations, you could carry out investigations in hematological, biochemical, immunological markers of liver fibrosis and genetic analysis. So the next test will be urine test. So for urine test, you can look for the levels of bilirubin and urobilinogen in the patient's urine. Other than that, you can also do imaging techniques to define the gross anatomy of the liver mainly. And then lastly, liver biopsy. Liver biopsy is usually done in an extreme cases like cirrhosis are usually like to study the histology of the liver. Next. So, investigations which are specific for this case, which is alcoholic liver disease, will be the first thing will be blood investigation. So, as you can see, first of all, in the blood investigation, if we can see for the red cell count, red blood cell count. So if it shows a high and mean corpuscular volume, it indicates heavy drinking. So high mean corpuscular volume can be due to heavy drinking, and this patient is also having mild anemia. As for liver biochemistry, this patient's ALT and AST is elevated. So ALT and AST will be elevated usually in fatty liver and alcoholic hepatitis. And if GGT is elevated, then it kind of confirms that this patient is drinking heavily. And as for liver function test, this patient is having high serum bilirubin and prothrombin time, low serum albumin, especially in patients with alcoholic hepatitis. So other than that, we can always do an imaging test to see the structure of the liver. So an ultrasound and a CT scan is considerable to look for splenomegaly, liver architecture, and focal lesions. So the last investigation will be a liver biopsy, and this is only if required to study the histology of the liver. Next. Here are some pictures that I've attached. So this is a picture of the ultrasound of a cirrhotic liver. So as you can see, the picture of the liver on your right hand side, it is cirrhotic and it has like nodular margins and the borders are very irregular. Next. So this is a CT scan of the cirrhotic liver. So as you can see, your liver is on your left. So the margins of the liver are very irregular and like you can see like little nodules. Next. So as for the management of any jaundice and liver disease, alcoholic liver disease, first of all, you have to stabilize the patient. Look for if the patient is going like hypotension or dehydration, always stabilize the patient and close monitoring of vital signs is required. Other than that, the general advice will be ask the patient to stop alcohol and also to stop high-risk behavior such as sex with any intravenous drug users. And also, it is very advisable for the patient to follow a balanced diet. So next will be three precipitating factors of decompensation of the liver. So usually what you do is you will replace the intravascular volume if it is depleted due to anemia, and then you will also give antibiotics for any kind of infection. Next. So we also have to manage the complications from liver damage. So these are like a few main complications from liver damage. So the first complication will be ascites of liver edema. So as for non-pharmacological management, you can treat an ascites by asking the patient to restrict fluid and salt intake, and also to ask the patient to measure their daily body weight and record it every day. And as for pharmacological management for ascites and liver edema, you can prescribe diuretics, which is spironolactone, a potassium-sparing drug with furosemide, which is a loop diuretics. And then for variceal bleeding, the complication of variceal bleeding, you can always give non-selective beta blockers or suggest a variceal band ligation or also blood transfusion to replace the falling hematocrit. And then for encephalopathy, hepatic encephalopathy, usually constipation can cause it. So to reduce the constipation, you can give lactulose 2 to 3 times lactulose to ensure like the stools are washed out from the bowel. So to make sure like at least 2 to 3 times loose stools per day is been washing out. And then for the final complication is spontaneous bacterial peritonitis. So for any kind of infection, you always go with broad spectrum antibiotics. So in this case, we can give third generation cephalosporins and metronidazole. Next. Yeah, so these are our references for the case of hepatic jaundice.
All right, thank you, Ravina. Any questions?
Okay, take it up.
Sorry, in which lecture you cover child pill criteria? For liver, for decompensated liver failure? Are you going to cover that in surgery?
Um, so far, no, doctor.
Yeah, I think one another important thing to know is the Chowkey criteria lah. Okay, so I think you don't cover here, but you can do a homework later and then read on it. Yeah.
Correct.
Thank you.
Right.
Next.
Sure, doctor. Thank you.
Moving on, we have post-hepatic jaundice.
Okay, so Assalamualaikum and a very good afternoon, everyone. So today, Yasmin and I will continue the presentation with post-hepatic jaundice. So next slide, please. Okay, so this is the example of short cases that we obtained from Oxford Cases in Medicine and Surgery. So here we have Mrs. Gupta, a 43-year-old marketing director who attends her local A&E complaining of yellow eyes, nausea and pain in her abdomen. So it all started a few days ago after dinner when she developed a stabbing pain in the right upper quadrant. So the pain comes and goes several times a day, with each wave of pain lasting about 40 minutes. So she has developed smelly, loose stools that are slightly pale and her urine is dark. So her past medical history is unremarkable. She takes no medication and does not smoke or drink. On examination, she is febrile but jaundice, and she is tachycardic and has tenderness on deep palpation of her right upper quadrant, and the rest of her examination is normal. So I'll be back in these cases throughout this presentation. So next slide, please. Okay, so I believe Haziq already explained about the metabolism of bilirubin, but I want to emphasize more on the events that happen in the post-hepatic. So for the post-hepatic, there are two major events that happen. The first one is bile secretion from hepatocyte. So conjugated bilirubin is now released into the bile canaliculi, into the bile ducts, stored in gallbladder, reaching the small bowel through the ampulla of Vater, and finally enters the colon. The second one is intestinal metabolism and also renal transport. So as we know, the intestinal mucosa does not reabsorb conjugated bilirubin due to its hydrophilicity and large molecular size. So the colonic bacteria deconjugate and metabolize bilirubin into urobilinogens, which 80% gets excreted into the feces and strucobile, and the remaining about 10 to 20% undergoes enterohepatic circulation. Some of the urobilins are excreted through the kidneys, imparting the yellow pigment of urine. So as a recap, dysfunction in prehepatic phase result in elevated serum levels of unconjugated bilirubin, while any insult in posthepatic phase marks elevated conjugated bilirubin. For hepatic phase, the impairment can elevate both unconjugated and also conjugated bilirubin. So increased urinary excretion of urobilinogen can be due to increased production of bilirubin, increased reabsorption of urobilinogen from the colon, or decreased hepatic clearance of the urobilinogen. So next slide, please. So in post-hepatic jaundice, also known as obstructive jaundice, there is an impediment to the flow of bile due to a partial or complete obstruction of the extrahepatic biliary passage between the liver and duodenum. So this obstruction can occur within the biliary ducts themselves or more distal within the pancreas. And as I mentioned earlier, this is predominantly a conjugated hyperbilirubinemia. So next one. So post-hepatic obstruction can be located in several different areas of the biliary tree and can be due to a variety of benign and malignant pathologies. So for benign pathologies, choledocholitasis is one of the benign causes that can cause post-hepatic jaundice. So cholelithasis involves the presence of gallstones, which are concretion that form in the biliary tract. Usually, it forms in the gallbladder, while cholelithasis refers to the presence of one or more gallstones in the common bile duct, and it impedes the flow of bile from the liver to the intestine. So this obstruction causes pressure that rises, resulting in elevation of liver enzymes and also jaundice. So the second one is Mirizi syndrome. This is quite rare. So Mirizi syndrome is an unusual presentation of obstructive jaundice caused by extrinsic compression of an extrahepatic biliary duct from one or more calculi within the cystic duct or gallbladder. So patients with Mirizi syndrome may present with recurrent episodes of jaundice and also cholangitis. It can be also associated with acute cholecystitis. So the next one, bile duct stricture, which is abnormal narrowing of the common bile duct. As we know, common bile duct is a tube that moves bile from the liver to the small intestine. So a bile duct stricture can be caused by chronic pancreatitis and also primary sclerosing cholangitis. And the next one is choledochosis. So choledochosis is a congenital bile duct anomalies, and this cystic dilatation of the biliary tree can involve the extrahepatic biliary or intrahepatic biliary radicals, or also sometimes both. So for malignant pathologies of post-hepatic jaundice, the first one is pancreatic tumor that can be either solid or cystic, and the second one is cholangiocarcinoma, which is a malignant epithelial tumors arising from the biliary tree, excluding the gallbladder or ampulla of Vater. So one of the common type of cholangiocarcinoma is Klatskin tumor. So Klatskin tumor is actually a term that was traditionally given to HeLa cholangiocarcinoma. So this type of tumor occur at the bifurcation of common hepatic duct, and typically these tumors are small, purely differentiated, exhibit aggressive biologic behavior, and tend to obstruct the intrahepatic bile duct. The next one is ampulla of Vater, or known as ampulla of Vater tumor, or known as ampullary cancer. So actually ampullary cancer is a rare type of cancer, and it's when cancer starts in the part of the body called the ampulla of Vater. So as we know, the ampulla of Vater is a small opening where the pancreatic and bile duct from the liver will connect to the first part of the small intestine, which is the duodenum. So for pediatric, biliary atresia is one of the common causes of post-hepatic jaundice that we can found in pigs. So biliary atresia is characterized by obliteration or discontinuity of the extrahepatic biliary system, resulting in obstruction to bile flow. So post-hepatic jaundice also can be caused by iatrogenic factors such as common bile duct injury following laparoscopic cholecystectomy, and also ischemic stricture from cautery or hepatic artery injury. The next one. Okay, so distinguishing between pre, intra, and also post-hepatic can be difficult. So it is extremely important to obtain a truly history and physical to help distinguish the underlying pathophysiology of the jaundice. So I'll be focusing more on the points to be elicited on the post-hepatic jaundice case, since I believe a lot of points already covered by Chang previously. So for history, the history of present illness should elicit a wide range of possible symptoms associated with jaundice. So patients with obstructive jaundice often produce pruritus, pale stools, and also dark-colored urine. So abdominal pain along with fevers and jaundice is suggestive of obstruction with an associated infection, also known as cholangitis. So a malignant source of obstruction more often present with painless jaundice and also weight loss. So risk factor for gallstones and possible cholelithiasis are important to obtain. So this include obesity, female gender, and age more than 40 years old. So any iatrogenic intervention such as surgery or endoscopy are critical to obtain, because as I mentioned earlier, iatrogenic factors also one of the causes that can cause post-hepatic jaundice. Now moving on. Okay, so for physical examination, a palpable gallbladder, mass in the abdomen, or lymph nodes in the supraclavicular area, also known as Richard's nodes, are suggestive of a malignancy causing obstructive jaundice. So the following terminology is important to know when diagnosing jaundice. The first one is Charcot's triad, which is the combination of jaundice, fever, usually with rigors, and right upper quadrant abdominal pain. So it occurs as a result of ascending cholangitis. So the second one is Reynolds-Pente, which is a collection of signs and symptoms suggesting the diagnosis of obstructive ascending cholangitis, which is a serious infection of the biliary system. So for Reynolds-Pente is actually a combination of Charcot's triad with shock, which represented with low blood pressure and tachycardia, and also altered mental status. So the next one is curvature sign or loss, which is enlarged, non-tender, and palpable gallbladder in patient with obstructive jaundice due to tumors of the biliary tree or pancreatic head. So the last one, I believe it's more common to us, which is the Murphy sign. So positive Murphy sign, if uh, positive if patient experience right upper quadrant tenderness and stop breathing upon inspiration as the gallbladder moves down in contact with the examiner's hand. So positive Murphy sign may be suggestive of activities. So, we pass to Yasmin for lab and management.
Sorry, Kama. Go on to the previous slide, please. Okay. So what do you do if you got this physical examination? Okay. So what are the summary of this slide? You take the history and you got the physical examination. So what is the summary after you read the second slide?
I'm sorry, Doctor, the summary of the slide.
Yeah. Physical examination. What does it show you? If you are in emergency department, right? Who would you call? Which team you want to call? Which team you want to refer at this point?
I'm not really sure, Doctor.
You're not really sure. So there's a lot of team, in emergency kan, a lot of team. You nak refer siapa, you nak masukkan ward mana, things like that. Okay, so basically post-hepatic jaundice is totally surgical case. It's not even medical case. You see, all are obstructive jaundice. Okay, so because it starts at the common bile duct, right? So anything obstructed there and cancer, all are surgical case. So it is important to know this. Is this intrahepatic, prehepatic, or posthepatic, especially in when you are the front liner, because you would know which team are the best for the patient to manage the patient. Okay, so posthepatic, highly likely they are surgical cases, and your investigations later after this should direct you towards surgical interventions. Understand? Okay, so let's see your investigation.
Okay, next I will continue presenting on the investigation for the post-hepatic jaundice. So for the lab test, firstly we can do the liver function test. We can see the level of bilirubin because the patient has jaundice. Next, we can see the liver enzymes such as ALP, GGT, ALT, and AST. But for post-hepatic jaundice, so because it's usually obstructive jaundice, means that there is obstruction in the bile duct. So usually the ALP will increase greater compared to the ALT and AST. And and if ALP and GGT increase, means that it is more to bile duct obstruction and gallbladder inflammation. Next, we can see the full blood count. We can see the level of neutrophil, white blood cells, if there's in infection, so it will increase, and the level of ESR and CRP. So if increase in this inflammation marker, so it may suggest cholangitis. Next, we can do the imaging. So firstly, we can do the transabdominal ultrasound. This is actually the gold standard for imaging of the gallstone. So from the ultrasound, we can see the extrahepatic obstruction and gallstone-related disease. So from the ultrasound, we can see the size and dilatation of the bile duct and also the level of the obstruction. Next, we can do the CT scan to detect any bile duct dilatation. Next, we can do the magnetic resonance cholangiography, the MRC. So the MRC is the method is used. We use the MRI to produce more detailed picture of the biliary tree, which consists of the gallbladder, liver, and bile duct. And we can also see to detect common bile duct stones. Next, we can do the HIDA scan. So the HIDA scan is when we inject the HIDA, which is the hepatobiliary immunodiacetic acid, into patient, and then the HIDA will taken out by the gallbladder, and we can see the functioning of the gallbladder through HIDA scan. Lastly, we can do the endoscopic retrograde cholangiopancreatography, which is the ERCP, to detect patient with bile duct that cause pancreatitis, jaundice, and cholangitis. But usually the ERCP is for treatment, usually in to remove the excessive bile from the bile duct. Next. So this is the ultrasound at the left picture. So we can see the gallstones in the gallbladder, and also the right picture we can see the normal HIDA scan to see the function of the gallbladder. Next.
We don't usually do HIDA scan.
Yeah, we don't. Okay. Yeah, we do HIDA scan when the ultrasound is inconclusive. Means that if there's any acute inflammation of the gallbladder, so then we do the HIDA scan.
But really also we go to CT scan straight away.
Oh yeah, okay. Okay, doctor. Okay, next.
I just see the functions of the gallbladder, right? And it doesn't add on to the management. Whereas in CT scan, you know the level of the stones. Okay, whether it's in bile duct, whether there is also in the gallbladder. The thing is, ultrasound is really technician dependent. So just imagine if you are a junior MO doing an ultrasound versus a consultant doing an ultrasound, you might see different things lah. The consultant might see small things that a junior doctors might not see, things like that. Okay, so CT is more sensitive in terms of detecting small stones. And another thing is, we talk about ERCP just now. ERCP is a good diagnostic and therapeutic tools. So when you can do the diagnosis in diagnosing where is the obstruction, and in the same way put a stent or do a removal of the stone, things like that at the same time. Okay. Yeah.
Okay, all right, doctor. So moving on to the management of the post-hepatic jaundice. So usually if the patient have gallstone, so we can do the cholecystectomy, which is removal of the gallbladder. So usually we do this when the patient is symptomatic, because usually patient with gallstone is symptomatic, and we usually detect patient with gallstone usually in incidental finding through ultrasound. So and when we remove the gallbladder, the bile will directly flow from the liver, directly flow to the intestine. So yeah. Next is the stone dissolution and shockwave lithotripsy. For this, it's infrequently used for gallstone because it's usually used in kidney stone. But we can also do this for patients that cannot undergo cholecystectomy. And for the stone dissolution, usually we give ursodiol, which is a natural occurring bile acid that helps to dissolve cholesterol stones when taken by mouth 2 to 4 times a day. But ursodiol is only for cholesterol stones. Next is antibiotics like penicillin, ceftriaxone, metronidazole, and cryptofloxacin. We can give this for the patient that have acute cholangitis. And lastly, we can do urgent endoscopic bile duct drainage if the patient may have acute gallstone pancreatitis. Next.
So what's the definitive treatment for acute cholangitis? Is it antibiotics? Are you implying that?
Yeah, because if there's inflammation, so it may have an infection. So that's why we give antibiotics.
Is it definitive?
Definitive. Sorry, Doctor, what do you mean by?
Is it definitive treatment or is it an adjunct? Definitive means you're going to cure this patient. Okay, it's definitive therapy.
Oh, it is. I think it's adjunct because.
So you have to reduce the inflammation and the infection first, Okay, but the definitive treatment is actually surgery. Okay, you have to remove the stone. Yeah, you have to remove the stone. Anyway, you cannot just discharge the patient with acute cholangitis or with antibiotics, the inflammation, infection resolve, you discharge, cannot. Okay, so you should remove the stone. If not, the patient will go another cycle, infections, ascending cholangitis, shock, and at that time ada high mortality lah.
Right,
So
doctor.
then let the patient go into another sepsis and then shock. Okay.
Okay. Okay, next. Okay, so here is the summary table for biochemical parameter for prehepatic, hepatic, and cholestatic jaundice. So in blood, we can see unconjugated bilirubin increase in prehepatic and hepatic jaundice, while conjugated bilirubin may increase in hepatic and cholestatic jaundice. For the alkaline phosphatase, which is the ALP, usually it increase in hepatic and more in cholestatic jaundice. For transminases, which is the ALT and the AST, it increase more in hepatic jaundice because hepatic if there's any liver disease or liver cell injury, so the ALT and AST will increase, and also in cholestatic jaundice. So for the urine, in urinalysis, the bilirubin usually can be found in hepatic and cholestatic jaundice, while the urobilinogen can be seen in hepatic jaundice, but decrease in cholestatic jaundice due to the obstruction of the bile flow. Next, that is all from us. This is the references. Thank you.
Okay, finish.
Yes.
That was the last slide.
Yeah.
All right. Okay. Well done, everyone. So I think what the take-home message from this tutorial would be how do you go with history taking, physical examinations, investigations, and then some sort of management. Okay, so it's different between three types of jaundice, and the patient might come with only one chief complaint, right? Only discoloration of the skin or discoloration of the sclera. Okay, but how you approach will lead you to the diagnosis. Okay, and when you take history of presenting illness, you have to cover a lot of systems pertaining to that chief complaint lah. Okay, so let's say if the patient has like pre-hepatic jaundice, there are pertinent history that will lead you to say that, okay, this is a pre-hepatic jaundice, these are the sets of investigations that I'm going to do. Okay, and then if this hepatic jaundice, there are sets of history that will be positive, and then that will lead you to the own physical examinations, and then history taking investigations. Okay, and also the post hepatic. Okay, for example, so pre-hepatic jaundice, hemolysis. Okay, you know this is hemolysis. You have to ask all about hematological system. Okay, like bruises. So no one asked about bruises just now. Okay, because these are hematological system, hemolysis, right? You have to ask about lymph nodes because they might have lymphomas, right? Okay, so why bruises comes because they might have thrombocytopenias. Okay, when there are a lot of obstructions and then your spleen is excessively working, you will also have this destruction of platelets as well. Okay, this happens in myeloproliferative disorder or a leukemic stage of lymphoma. Okay, so think about that. Think about hematological diseases and cover in your history of presenting illness. And then on top of that, you have to ask about malignancy in pre-hepatic jaundice, okay, and connective tissue disease. Don't forget about connective tissue disease in pre-hepatic. Okay, and then hepatic actually is the largest component in jaundice. A lot of investigations, and I think Ravina and Kama just covered a bit only. It's not a lot because apart from toxic, like alcoholic liver disease in this case, she might also have hepatitis. Okay, and I believe hepatitis has its own lecture after this, right? I think so. Okay, so if not, you better read a lecture on hepatitis lah, because it's part of your examination. Okay, your exam later, then of posting examination. Okay, and then cover on autoimmune hepatitis, a bit of autoimmune hepatitis as well. And then chronic liver disease. Okay, so these 4 things on hepatic jaundice. Okay, first, alcoholic is important. You have to know all the managements and then investigations and things like that. Alcoholic liver disease, hepatitis, A, B, C, you have to know. And then, as I said, a bit of autoimmune. And then number 4 would be chronic liver disease management. Okay, so what they need yearly, like surveillance for OGDS to look for esophageal varices and things like that. Child-Pugh criteria, these are all chronic liver disease segment. Okay, and then post-hepatic, I think it is the easiest because it's simple, and then you know that the definitive treatment for post-hepatic would be surgical. Okay, there might be infections like cholecystitis, infection, okay, ascending cholangitis, okay, infections. You have to treat with antibiotics, but the definitive treatment would be surgical. All right. And then I think after all, these are the key things that you need to know whenever you are presented with a case of jaundice in the exam. This is how you approach lah. You have to know this is pre, intra, or post. That will be easier. Okay. So any comments? No, any questions? Apart from the presenters, I know the presenters are experts now. No? All right. Okay. Can we end our class then? Yeah?
Yes.
All right. Okay. Thank you, everyone.
Thank you, everyone.
Thank you,
Right.
doctor.
Thank you,
Bye.
Doctor.
Presenter.